Hello and welcome to my channel Magic of Medicine. Today's topic is twin labeling. It is important so as to ensure that biometric measurements from consecutive longitudinal growth scans are allocated consistently to the same twin at each visit. Twin labeling creates a confusion amongst radiologists, gynecologists, and treating neonatologists. So, a reproducible method for antenatal labeling of twins is important in management of all twin pregnancies. The labeling of twins should be consistent and documented clearly in the report. Failure to do so may result in yo-yoing of fetal growth. This leads to claiming of the smaller twin as the larger twin in the subsequent pregnancy and the larger twin as the smaller twin, and the sizes are swapped repeatedly, creating the confusion. So today we will read about accurate method of twin labeling to swap off all of this confusion. So these are the four methods of twin labeling. First one is as per the sac position. It was highly used a few years back and people today also use this method, but the likelihood of peripartum switch leads to confusion amongst pediatrician and gynecologists, as the sac position claims the presenting twin as the twin 1 and the second twin as the twin 2, but during the peripartum switch it just gets vice versa. So it is not recommended nowadays. So do not use this method. Better method is use the laterality method or the vertical orientation method. It is the most reliable method. Third one is placenta position. You just claim the fetus with the placenta posterior or the placenta anterior. However, it cannot be used in monochorionic twins and fused dichorionic twins because both of these twins will have a single placenta. So there is not any demarcation. And the last method is as per the cord insertion at placental end. This method is quite famous for detection of monochorionic twins. You can label monochorionic twins by this method. So coming to the first method, that is as per the sac position. In this method, twin A is claimed as the twin with sac nearest to the cervix, and twin B or twin 2 is the twin with sac away from the cervix. So look here. Here this is the cervix, this is the uterus, and this one is nearest to the cervix. So this is twin 1 and this one is twin 2. But the position of G-sac in maternal cervix is relative, because now this fetus can go inferiorly and this can go superiorly, creating the confusion again as which one is the presenting one. So the crux of this is the position of G-sac in relation to maternal cervix is used to determine the twin labeling in early pregnancy, because the G-sac position relative to cervix remain constant throughout the pregnancy, while the positions of either fetus can keep on changing. So as per the sac position method, since this sac is nearer to the cervix, this one is the twin 1 and this one is twin 2. However, Nowadays, sac position method is not recommended. Nowadays, the best method of labeling is according to the laterality or vertical orientation. Laterality is when there is the intertwin membrane running vertically along the longitudinal axis of the uterus, dividing the uterus into right and left half, and thus you can tell the right fetus as twin 1 and the left fetus as twin 2, or vice versa. That is, you can tell right or the left. And then be static or be constant in consecutive scans. But if the intertwin membrane is running horizontally across the longitudinal of the uterus, then it is dividing the uterus into top and the bottom half, and the fetus can be claimed as fetus superior or top, or fetus bottom or inferior, as fetus A and fetus B. There is no AP dividation in uterus because AP diameter of uterus is very small, hence only there are two possibilities, that is either right or left or top and bottom. There is no antero-posterior possibility. So what you have to do is you have to look for intertwin membrane. If the intertwin membrane is vertically, then claim the fetuses as per right and left, as twin 1 and twin 2. And if the intertwin membrane is running horizontally to the uterine axis, then claim the fetus as top and bottom as T1 or T2, any of which is suitable. But just be consistent. Fetus top will be always the fetus top, and fetus bottom will be always the fetus bottom. Fetus right will be always right, and fetus left always left. This, mind you, this is maternal right and maternal left, maternal top and maternal bottom. So it is the most reliable method. It has two benefits, that is, there will be consistency throughout the pregnancy and hence it will be reproducible. Second, it remains constant because the intertwin membrane is a fixed structure. This fetus cannot go this side and this fetus cannot go this side. The only drawback of this method is you cannot apply it in cases of monochorionic twins, because then in those cases there is no intertwin membrane. But I already told you before, if there is a monochorionic twin, use the placental cord insertion method. You can tell the fetus 1 as the fetus which has the cord insertion superiorly, and fetus B as a fetus which has cord insertion inferiorly, likewise. So the take-home message from this talk of twin labeling is: describe each twin using as many features as possible so as to reproduce the labeling in subsequent scan and identify them correctly. So if you have a twin A, you tell its lateralization, plus you tell its placenta, and plus the cord insertion, example if the cord is marginal or wherever it is located. So in this way you have the maximum identification features of a twin labeled. So by this way, a fetus A will be fetus A throughout the pregnancy, fetus B will be fetus B throughout the pregnancy, and your scans will be accurate throughout the pregnancy. The growth scans will correlate, the anomalies will correlate, and your gynecologists and pediatricians will be happy from the reporting. Thank you for watching the video. If you found this video about twin labeling method, please like, share and subscribe.